You break your arm, you go to the hospital. I mean, you have a persistent fever, you go to the local clinic.
Right. It's just what we do.
Exactly. For our entire lives, we've been completely conditioned to view these buildings as, sanctuaries of healing.
Yeah, safe spaces.
But what happens when the very places you go to get cured, like the waiting rooms, the examination tables, the equipment, are actually biologically engineered to amplify the next great pandemic?
It's a terrifying thought. I mean, it completely shatters our foundational understanding of medicine. We treat hospitals as these sterile safe havens. But the reality of modern microbiology, combined with human behavior, it turns these facilities into the ultimate training grounds and distribution centers for drug-resistant pathogens.
Which is exactly why we're here. Welcome to this deep dive. Today, we have an incredibly urgent mission. We are unpacking the looming global crisis of antimicrobial resistance, or AMR, and the structural flaws in our current healthcare systems.
Yeah, and we're looking at a diverse stack of sources today.
Right. We've got medical journal articles on AMR in India, World Bank and Observers Research Foundation reports, the Tackling Drug-Resistant Infections Globally review, plus transcripts from health tech podcasts and extensive project proposals on a new AI called Dr. Maya.
It's a lot of material.
It is. But our mission is to equip you, listening right now, with a profound understanding of why the current hospital-centric, doctor-dependent medical model is essentially a ticking time bomb against superbugs.
Oh.
And then we're going to present a compelling, evidence-based pitch for a paradigm-shifting alternative.
Because, to actually solve this crisis, we have to stop looking at medicine purely through the lens of diagnose and treat.
Right.
The era of just handing out a pill is ending. We have to examine the hidden systems of transmission, the economics of care, and the physical spaces where that care actually happens.
Okay, let's unpack this. To understand the macroscopic failure of healthcare, we really have to look at India. And, if you don't live in India, you might be wondering why this matters to your local hospital or your family.
Oh, but it matters immensely.
Exactly, because India is the ultimate microcosm. It is a massive, real-world stress test for the global healthcare architecture. I mean, if a system fails there under the weight of population, economics, and disease, it exposes the exact vulnerabilities inherent in every single nation's system.
Yeah, it's a structural baseline.
Right. And the baseline dysfunction there is a system that is deeply divided between public and private care.
The landscape there is just a study in extreme contradictions. On a global scale, India is known as the pharmacy of the world.
Right. They produce a massive amount of drugs.
Massive quantities. The globe's medications, generic drugs, vaccines, you name it. Yet domestically, public health spending has historically been just abysmal. We are looking at figures around $73 per capita.
Wait, $73?
Yeah, 73. And to put that in perspective, the global average is over $11,110.
Wow. That is a massive gap.
It is. And that chronic underfunding creates a massive vacuum in public care.
And, well, nature abhors a vacuum. When the public system is starved of resources, the private sector rushes in to fill the void, right?
Exactly.
And the numbers from the sources here are staggering. Even though the public system is theoretically cheaper or even free, 58% of the rural population relies entirely on private health care.
Which sounds counterintuitive.
Right. But here is the statistic that really stops you in your tracks. When you look at the poorest quintiles, like the absolute lowest income brackets, over 50% of their medical dependence is still on the private sector.
Yeah.
Why would people who are struggling to afford basic food bypass free clinics to pay for expensive private care?
Well, it's because the public system in many of these areas simply isn't reliable. I mean, imagine you walk miles to a public clinic only to find absentee doctors or stockouts of basic medicines or diagnostic equipment that just hasn't worked in months.
So they just can't get the care they need.
Right. So patients get desperate. They enter this highly fragmented system. The term for this behavior in the literature is zigzagging. They lack a trusted medical home.
It's almost like a pinball machine.
That's a great analogy.
The patient is the ball, and they are launched into this chaotic system. They bounce from an unqualified local practitioner, hit a bumper, and bounce to an underfunded public clinic, realize there's no doctor there, and then ricochet into an expensive private nursing home.
Yeah, zigzagging erratically to find relief.
And at every single bumper, they are losing money.
That is exactly how it functions. And that zigzagging comes at a catastrophic economic cost. Out-of-pocket expenditure in these private hospitals is nearly 5 times higher than in public ones.
5 times?
Yes. And we need to define what that actually means for a family. Let's say a private hospital charges between 3 to 12 lakhs for a severe hospitalization.
And a lakh is 100,000 rupees, right?
Exactly. So we are talking about hundreds of thousands of rupees. That is an insurmountable fortune for an uninsured family.
So they are taking out high-interest loans,
Right.
selling their livestock, selling their land. I was reading that these health expenditures push around 39 million Indians into extreme poverty every single year.
39 million.
39 million people losing their entire economic footing, not because of a stock market crash, but just because they got sick and tried to get better.
It's devastating.
It really is. It's an illusion of private superiority. We have this global psychological bias that assumes because we pay top dollar for something, it must be better,
Yep.
safer and more resilient.
But the COVID-19 pandemic completely shattered that illusion of resilience.
Oh, absolutely.
When a true crisis hit, the very private system that over half the population relied upon essentially collapsed, or worse, became highly predatory.
When you say predatory, what exactly were the mechanics of that? How did the private sector actively make the pandemic worse?
Well, it really came down to financial extraction and risk avoidance. Uninsured patients were suddenly hit with those massive multi-lakh fees just to secure a bed.
Just to get in the door?
Yeah. But beyond the financial ruin, many of these private facilities completely failed to follow basic infection control protocols.
Why? I mean, they're hospitals?
Because they weren't structurally designed for isolation, they were designed for high throughput and profit. So they became active hubs of infection. And when the logistical challenges of oxygen supply and staffing got too difficult, many private hospitals simply shut their doors.
Wow.
They just gave up,
They opted out of the crisis entirely.
leaving the chronically underfunded public infrastructure to absorb the entire shockwave.
Exactly.
Which is what led to the horrific oxygen shortages, the overflowing wards, and the systemic collapse we all witnessed on the news. The architecture didn't just bend, it broke.
It completely broke.
So let me throw this out there. If the public system is chronically underfunded, and the private system is basically a financial trap that actively shuts down when a pandemic hits, aren't we learning the wrong lesson if our only solution is to build more hospitals?
I would argue yes.
Like, if a government just throws $1 billion at building a shiny new hospital, does that actually solve the underlying vulnerability? The evidence points to a definitive no. Building a newer, more expensive version of a broken model doesn't fix the fundamental flaw.
Right.
Because the financial and structural failure we just discussed, that's really only half the story. The physical buildings themselves, the way they intentionally concentrate sick, contagious people in waiting rooms and wards, that is where the biological failure happens.
And that biological failure is far more terrifying than the economic one.
Without a doubt.
Which brings us to antimicrobial resistance.
Yeah.
AMR. The silent pandemic. I think most of us have a vague high school biology understanding of antibiotic resistance. Like, you take too many pills, your body gets used to them, and they stop working.
Let's correct that misconception right away because it's vital.
Okay, lay it on me.
Your body doesn't get used to the antibiotics. The bacteria do.
Right.
AMR happens when bacteria, fungi, viruses, and parasites actively evolve to defeat the drugs designed to kill them. It is an evolutionary arms race, and right now, the microbes are winning handily.
But how exactly are they doing that? They aren't just magically becoming immune, right?
No, not at all. It's highly mechanical. Bacteria multiply incredibly fast. Every time they multiply, there's a chance for a genetic mutation.
Okay.
If you introduce an antibiotic, you kill the weak bacteria. But the ones that randomly mutated to survive the drug, they are left behind.
Because the antibiotic couldn't kill them.
Right. And now they have no competition for resources, so they multiply. But completely different types of bacteria.
Wait, really? How?
Through a process called horizontal gene transfer.
So it's like they have tiny USB flash drives loaded with the blueprints on how to defeat our best drugs, and they just pass them around to each other.
Exactly. Plasmids. They hand these genetic blueprints to their neighbors. So a completely harmless bacteria on your skin can hand a resistance blueprint to a deadly staph infection.
Oh, wow.
And the scale of this is jaw-dropping. In India alone, AMR causes more mortality than cancer, tuberculosis, respiratory infections, and diabetes combined.
That is horrifying. More than all of those combined?
Yes.
And the projections for the future. Like, where is this going?
Well, by 2050, if the trajectory holds, AMR is expected to cause 2 million deaths annually in India.
2 million.
And between 10 to 16 million deaths globally every single year.
16 million people dying from routine infections that we used to just treat with a simple course of pills.
Exactly. A scraped knee, a routine surgery, childbirth. All of these become potentially lethal.
And this is being fueled by a lethal mix of causes, right?
Right.
You have the socioeconomic factors.
Right. High-density poverty, lack of clean water, poor sanitation.
But you also have the intense pharmaceutical pressure to sell antibiotics as a quick fix, leading to rampant self-medication. I mean, people buy antibiotics over the counter. They start a course, they feel better in 2 days, and they just stop taking them.
Which is the worst possible thing you can do.
Because it doesn't kill all of them.
Exactly. By stopping early, you don't eradicate the infection, you just expose the bacteria to a non-lethal dose of the drug. It's quite literally training them. You've killed the weakest ones and left the strongest ones to multiply.
We are basically sending the bacteria to a specialized gym to get stronger.
That's a perfect way to put it. And the results are already here. E. coli resistance to common antibiotics is skyrocketing. Drugs like ciprofloxacin and cefotaxime, these used to be our highly reliable, broad-spectrum heavy artillery.
And now?
Now their efficacy is frequently falling below 20%. We are firing blanks.
That's terrifying.
And what's fascinating here is how the physical environment of healthcare actively accelerates this. We mentioned the paradox of the hospital earlier.
Right, that we view these buildings as sterile.
Exactly. But it is practically impossible to sterilize a working, breathing hospital.
Here's where it gets really interesting and honestly deeply unsettling. Let's break down the myth of the sterile hospital, starting with the uniform, the traditional white coat. It is the ultimate symbol of cleanliness and medical authority. But the reality is a nightmare.
It really is. The clinical data on this is robust. Studies show that between 70 to 95% of white coats worn in active clinical practice carry potentially pathogenic bacteria.
Wait, 95%?
Up to 95%, yes. And methicillin-resistant Staphylococcus aureus, or MRSA, which is one of the most dangerous superbugs on the planet, is found on 4 to 6% of them.
That is insane.
And the bacterial load doesn't just sit there, it actively increases throughout a doctor's shift.
Well, because think about the mechanics of a doctor's day. They are leaning over patients, they're brushing against bed rails, reaching into pockets, resting their elbows on nursing station counters.
There's constant contact.
So the sleeves and the pockets become these mobile reservoirs. They are transporting pathogens from room A down the hall to room B, and then into the hospital cafeteria.
Precisely. They're essentially acting as a shuttle service for superbugs. And it's not just the fabric of the coats. Consider the stethoscope.
Right, the tool that literally touches every single patient's skin.
Yes. The research shows that 30% to 100% of stethoscopes are heavily contaminated.
100% in some studies.
Yes. The bacterial load on the diaphragm of a stethoscope, you know, the flat metal part they press against your chest or your back, is entirely equal to the bacteria found on unwashed hands.
But wait, doctors know this, right?
Yeah.
Don't they wipe them down with alcohol pads between patients? I've seen them do it.
Well, in theory, yes. In practice, the compliance rate is abysmal. Data indicates that only about 21% of healthcare workers regularly clean their stethoscopes.
Only 21%.
Yeah, and virtually none clean them after every single patient encounter. The time pressure, the sheer volume of patients in a crowded clinic, it just makes it practically impossible to maintain rigorous sterilization protocols.
I mean, I guess that makes sense when you've got a waiting room packed with people.
Exactly. And it gets even more complicated with intricate tools, like otoscopes, the tool they use to look inside your ear canal, and ophthalmoscopes for your eyes.
Oh, because they have weird little parts.
Right. They have narrow, inaccessible parts. They are incredibly difficult to clean thoroughly, making them perfect hideouts for microbes.
But surely the personal protective equipment, like the PPE, keeps the doctors and the patients safe. I mean, the face masks, the gowns, the blue shoe covers we saw everywhere during COVID.
That's another misconception. We view PPE as an impenetrable shield, but it is only a shield while it is being worn perfectly.
Right.
The moment you have to take it off, it becomes a severe liability. If hand hygiene compliance is sitting around 40% in many busy wards, the removal of PPE becomes an active source of cross-infection.
Because you have to touch it to take it off.
Exactly.
Imagine a doctor wearing a blue protective shoe cover. They walk through an intensive care unit floor, picking up invisible, highly resistant bacteria.
Yes.
When their shift is over, they bend down to peel that shoe cover off. If their technique isn't absolutely flawless, their thumb brushes the outside of the cover.
And there it is.
They've just transferred the superbug from the floor to their hand, and then they touch a door handle or a chart or a bedsheet. The illusion of safety is actually creating a false sense of security that drives transmission.
This specific mechanism of transmission is exactly why the growing trend of healthcare ATMs is so heavily criticized by epidemiologists right now.
Yes, let's talk about these, because we are seeing these pop up everywhere, in shopping malls, local pharmacies, corporate lobbies.
Yeah, they're very popular.
There are these automated kiosks where you sit down, put your arm in a cuff to measure your blood pressure, grab a handle to check your heart rate, maybe use a touch screen to input your symptoms.
And look, it sounds like a great preventative measure,
Yeah.
right? Bringing health share directly to the community.
Sure, it sounds super convenient.
But mechanically, they are incredibly dangerous. Because they require direct physical contact with cuffs, probes, and screens, they simply become decentralized hubs for spreading exactly the pathogens we are trying to fight.
This is a massive aha moment. The very tools of diagnosis have become the vehicles of transmission.
Exactly.
You cannot adequately sterilize a public blood pressure cuff between every single user in a busy shopping mall. It's impossible.
Nobody is standing there doing a deep clean after every person.
Right. So if someone with an undiagnosed drug-resistant fungal infection uses that machine, the next 50 people who check their blood pressure are exposed.
They are essentially physical sponges for community pathogens. So when you or a loved one rushes to the emergency room or sits down at a diagnostic ATM for a minor scare, maybe a bad cough or a weird rash, you are willingly walking into a highly concentrated environment actively colonized by organisms that our strongest drugs can no longer kill.
You are stepping into the danger zone just to get a diagnosis.
Precisely.
Because if the physical buildings are contaminated, the doctor's clothes are contaminated, their stethoscopes are dirty, and physical ATM kiosks are just transmission hubs. Why can't modern digital technology solve this?
Yeah.
I mean, we all have smartphones. Why can't current AI symptom checkers, the apps we already use, just fix the diagnosis process remotely without us ever touching a dirty surface?
It comes down to a foundational flaw in how those digital systems are designed, and this taps into a deep psychological bias we all share, our desire for binary biology.
What do you mean by binary biology?
Well, we want medicine to be like a digital X-ray. You look at the scan, you see a jagged white line, and the doctor says, your bone is broken, yes or no, 1 or 0.
Right, clear answers.
Exactly. We want an app to tell us definitively, you have disease X, take pill Y. We want clean, categorizable answers.
But emerging infections and superbugs don't play by binary rules. The landscape is murky.
Highly murky. Current AI symptom checkers are essentially digital flowcharts. They are built on Bayesian probability network.
Okay, what does that mean in plain English?
It means they look for symptoms that are statistically linked to specific known infections. If you input fever over 101 and persistent dry cough, the logic gate triggers an alert for a respiratory infection. They operate purely on rigid statistical significance.
But a drug-resistant organism might hide in plain sight. It might present as a painless pimple on your leg, a faint rash you barely notice, unexplained night sweats, or just an unusual sense of fatigue.
Yes.
A rigid app misses these subtle signs because a single painless pimple isn't statistically significant enough on its own to trigger a severe alert in a standard flowchart algorithm.
Exactly. The algorithm dismisses the subtle cluster. And even when an app does manage to flag something concerning, what is the ultimate output? What does the app tell you to do?
It tells you to go see a doctor. It says seek medical attention immediately.
Which throws you right back into the diagnostic trap.
Right back into the contaminated hospital.
Yes, and we saw this play out globally with COVID-19. Public health policies forced potentially infected, highly contagious people to travel.
Oh man, yeah.
They got on public transport, sat in crowded waiting rooms, and stood in long lines at centralized testing centers, often to get swab tests that weren't even 100% accurate.
We literally used the civilian population as a transport mechanism for the pathogen.
We did.
We forced sick people to move around the city to confirm they were sick, exposing the bus drivers, the receptionists, and the immunocompromised patients sitting in those same waiting rooms.
Centralized testing actively facilitates the spread of the infection. And we have to accept a very hard truth about modern medicine here.
Which is?
The era of diagnose and eradicate is ending. No doctor can offer a guaranteed cure for a superbug infection anymore. They can only offer prevention, supportive care, and early intervention.
That is a chilling thought. We are so used to the idea that there is a pill for everything.
But there isn't anymore. The pipeline for new antibiotics is completely drying up.
Really? Why aren't they just making new ones?
Because pharmaceutical companies have largely stopped investing the estimated 1 billion pounds it takes to research, trial, and develop a single new antibiotic drug.
£1 billion just for one drug.
Yes. And the business model for antibiotics is fundamentally broken. Imagine spending £1 billion in a decade to develop a revolutionary new drug. You bring it to market. Within months, the bacteria share those plasmid blueprints we talked about, and they develop resistance. Your £1 billion drug is obsolete before you've even recouped the research and development costs.
Wow.
The financial incentive to fight AMR using traditional pharmacology simply doesn't exist anymore.
So if you cannot cure the infection once it takes hold, and you cannot physically test for it without spreading it across the city, your entire centralized detection network is useless.
It is.
Public health officials only see the outbreak when people start showing up in the intensive care unit. But by then, the transmission chain is already miles long and completely out of control.
Exactly. And when the centralized medical system fails to spot the outbreak early, what is the only tool governments have left?
Lockdowns, the absolute bluntest instrument possible.
Precisely. If you can't see the pathogen, you have to freeze the entire society. And the collateral damage of lockdowns is explicitly clear.
We've all lived it.
Right. They bankrupt small businesses, sever supply chains, push millions of vulnerable people into extreme poverty, and decimate national economies. Relying on the hospital to spot the pandemic guarantees that you will have to lock down the entire society to stop it.
You know, if you look at the medical establishment's reliance on this centralized, doctor-centric diagnosis model, it was acting like an autoimmune disease.
How so?
It is actively attacking its own host. The very system meant to protect society is destroying its economic and social fabric. There's a fascinating historical parallel here from the sources. Look at Dr. Ignaz Semmelweis in 1847 Vienna.
Ah, yes, the pioneer of antiseptic procedures.
Right. He was a doctor working in maternity wards, and he noticed that women were dying of childbed fever at massive rates when treated by doctors who had just come from performing autopsies.
Right, they were going straight from the morgue to the delivery room.
Exactly. He figured out that if doctors simply washed their hands with a chlorinated solution before delivering babies, mortality plummeted. She had the data. He mathematically proved it.
And how did the medical establishment react?
They completely rejected him. They mocked him. They were actually offended by the implication that a gentleman's hands could transmit disease.
It's tragic.
He was essentially driven out of the profession and died in an asylum. He was punished severely for being right too early because his solution disrupted the ego and the established workflow of the centralized medical authority.
It really makes you think. It raises a vital question. Are we doing the exact same thing today with decentralized, patient-first artificial intelligence?
I think we might be.
Institutional leadership often publicly refuses to engage with diagnostic tools that don't involve a physical doctor, even when those tools demonstrably keep people safe and out of contaminated hospitals.
It is a systemic immune response against disruptive prevention. The system is economically incentivized to treat the sick in a hospital bed, not to keep them entirely out of the clinical pipeline.
Exactly. But if we are going to survive the post-antibiotic era, we must completely bypass that medical monopoly. We have to intercept the infection before it leaves the neighborhood.
Which leads us to the proposed paradigm shift, the specific solution we are analyzing today, Dr. Maya AI and the Prima Kiosk ecosystem.
This is where the technological architecture fundamentally shifts away from everything we've discussed so far. Let's start with the intelligence engine. What is Dr. Maya?
It's an AI clinical intelligence system.
Yeah.
But how is it different from the rigid flowcharts we just talked about? If it's not using a Bayesian probability network, what is it doing?
Dr. Maya GPT is fundamentally different because it is designed to mimic human clinical acumen, not just statistical box checking.
Okay, so it thinks more like a doctor.
Yes, it was developed by integrating over 50 years of nuanced clinical experience. Instead of just analyzing a list of discrete symptoms, it functions more like a large language model. It contextualizes unstructured data.
Like having a real conversation.
Exactly. It listens to the story of the illness as the patient experiences it.
So instead of asking, is your fever above 101, it's looking for the subtle narratives. Like someone saying, I've been sweating a lot at night, my heart feels a bit racy, and I've been incredibly irritable lately.
Right.
A standard app says, you're stressed, get some sleep. But Dr. Maya tracks these seemingly unrelated inputs locally and contextualizes them.
Precisely. By tracking these subtle combinations of symptoms, it can identify anomalies. If 3 people in the same apartment block report that same unusual cluster of sweating, palpitations, and mood changes within 48 hours, Dr. Maya recognizes the pattern of an outbreak.
That's incredible.
It sees the cluster forming days before anyone gets sick enough to require an intensive care bed or a ventilator.
This allows for a massive policy shift at the government level. It enables isolation over lockdown. Think about the economic implications of this. If public health authorities can spot a cluster instantly in one specific neighborhood, they can implement highly localized, precise quarantine measures.
Yes. You isolate the infected individual to protect the family. You isolate the family to protect the apartment block. You quarantine the block to protect the city.
You nip it in the bud.
Exactly. You do not have to resort to an economy-destroying national lockdown because you actually have granular, real-time visibility on the ground. You have a radar system for pathogens.
But the AI needs a way to interface with the public, right? It needs physical infrastructure. And that is the Prima kiosk. PRIMA stands for Personal, Reliable, Empowering Medical Access.
Yes, the physical hardware is crucial, especially in areas with low smartphone penetration or poor digital literacy.
But wait a minute. Pushback time.
Okay, let's have it.
Earlier, we established that healthcare ATMs, the physical kiosks in malls, were incredibly dangerous vectors for disease because they act as physical sponges for pathogens.
We did.
How is the Prima kiosk any different? Why won't this just become another hub for MRSA?
Because of a fundamental design difference. Cognitive triage versus physical diagnostics.
Explain that.
The Prima kiosk is entirely touch-light and information-based. It does not perform physical tests.
Okay.
There are no blood pressure cuffs to wrap around your arm, no heart rate monitors to grip, no stethoscopes to press against your chest.
So it's not taking my vitals at all? Isn't it just a glorified Google search then? How can it diagnose me without touching me?
Well, it's not providing a definitive medical diagnosis. It is providing highly sophisticated triage. It is categorizing risk.
Oh, I see.
Because it doesn't require the user to interact with physical diagnostic equipment, it does not harbor and transmit bacteria, fungi, or viruses in the way a diagnostic ATM does. The hardware can be wiped down easily because there are no intricate cuffs or rubber tubes. It relies entirely on the Dr. Maya intelligence engine interviewing the patient to assess the risk level of their symptoms.
Okay, cognitive triage. And it uses a very specific color-coded system to communicate that risk to the user. Let's walk through the mechanics of that because the behavioral psychology here is brilliant.
The system classifies risk into 4 distinct, easily understandable colors. Red means emergency.
Pretty universal.
Right. The AI detects a high likelihood of a life-threatening condition based on the symptom cluster and advises the user to call an ambulance immediately.
Makes sense.
Blue indicates an infection risk. This is the crucial AMR intervention. It flags a potential bacterial or viral spreading infection.
Okay, so what does the user do?
The advice is to see a general practitioner within 24 hours. But crucially, the doctor or clinic is digitally alerted that this specific patient is an infection risk before they walk through the front door.
Oh, wow. So they can get ready for them.
Exactly. The clinic can prepare isolation protocols before the patient ever enters the waiting room.
That is huge. What about yellow?
Yellow is moderate risk. This might be a condition that requires monitoring at home or perhaps a consultation with a local community pharmacist, but it does not require an immediate doctor visit or a trip to the hospital.
And green is reassurance, self-care, drink fluids, rest, no antibiotics needed. And this green category is arguably the most important one. Data from the sources suggests that up to 40% of emergency room demand is driven by anxious, healthy people rushing to the hospital for imaginary fears, minor illnesses, or somatic symptoms driven by stress.
It's a massive drain on resources. Think about the impact of removing 40% of the foot traffic from an emergency room.
It would be revolutionary.
By empowering the patient with immediate, reliable cognitive triage at the community level, the Prima kiosk stops that panicked rush. It keeps healthy but anxious people out of contaminated hospitals where they might actually catch something lethal.
And just as importantly, it protects the overworked healthcare workers from being exhausted by non-emergencies, allowing them to focus on the truly sick.
This raises an important question, though.
Which is?
Scale. Deploying 5,000 kiosks sounds great on paper, but getting people to actually trust an AI over a human doctor, especially in a rural village in India or a marginalized community anywhere in the world, is a massive behavioral hurdle. How does the system bridge that trust gap?
Right. If I'm a politician or a philanthropist looking at this, I need to know how this practically scales. Paint me the presentation.
The physical deployment strategy is designed specifically to bridge that trust gap. The kiosks do not require complex, expensive building projects. They can be standalone, rugged, and solar powered.
So they can go anywhere.
They can operate in rural villages, urban slums, remote tribal areas, but they aren't just dropped there automatically, they are managed by people.
The community health navigators.
Exactly. The kiosks create direct jobs for local operators. The deployment targets women, youth, or administrative staff in deprived areas. These navigators earn a living managing the kiosk, physically maintaining it, and most importantly, helping their neighbors use it.
So when a worried mother comes to the kiosk at 2 a.m., she isn't just staring at a cold machine. She is guided by someone from her own community, someone she recognizes, who helps her interface with the AI.
Yes.
That local human touch bridges the gap between intimidating advanced technology and rural populations.
And this actively reduces the gap between rich and poor by keeping the economic activity within the community. The local navigator earns an income, the patient avoids a costly and unnecessary trip to a private hospital, and wealth stays localized rather than being extracted by a distant corporate hospital chain.
Furthermore, it eliminates vast health disparities through language. The Prima kiosk operates in over 30 languages.
30 languages, yeah.
It bypasses the massive barriers of literacy and language that historically keep marginalized ethnic minorities or immigrants from accessing care. It can send critical health information in their native language directly to the user's phone via text or WhatsApp.
And think about the staggering cost savings at a government level. Governments currently spend absolute fortunes on massive public health advertising campaigns, mass random testing, and blind vaccination efforts.
Right. They buy billboards and TV ads hoping the right people see them.
Exactly. This targeted multilingual network bypasses all of that inefficiency. It communicates directly with vulnerable populations, the elderly in care homes, people living alone, or groups who historically have lower GP registration rates.
Let's translate this into the macroeconomics. If we map out the next 25 years, the trajectory of AMR is terrifying. We are looking at a steep climb to 16 million deaths annually by 2050. That is the business-as-usual scenario.
But the projections show that if the Dr. Maya intervention and the Prima kiosk networks are deployed globally, that curve dramatically flattens. It projects a reduction in annual deaths down to 3.6 million.
That is over 12 million lives saved every single year.
It's hard to even fathom that number.
That is the ideological return on investment. But what about the financial return? Let's look at the modeling for a national healthcare system, using the UK's NHS as a baseline example.
The economic modeling is incredibly compelling here. Let's say a government deploys 5,000 kiosks across the country. According to the data, if each kiosk gets just 10 users a day, that generates over 18 million cognitive consultations a year.
And the revenue model is straightforward. Even if there is a nominal fee or a government subsidy, just 10 users a day generates over £18,000 annually per kiosk, which sustains the local community health navigator.
Right.
But the real structural wealth isn't in the kiosk fees, it's in the massive savings to the state.
The modeling suggests that if only 10% of those 18 million kiosk consultations prevent an unnecessary visit to a general practitioner or a walk into an emergency room, it creates a 1 billion count opportunity in avoided costs and savings for the healthcare system.
£1 billion saved. And let's break down where that £1 billion comes from. It's not just the £50 cost of the doctor's time.
No, it's the downstream savings.
Right. It's the unnecessary broad-spectrum antibiotics that aren't prescribed. It's the lab tests that aren't run. It's the secondary MRSA infection the patient didn't catch because they stayed home. It's the days of work they didn't miss traveling to a clinic.
The ultimate vision presented here is profound. This isn't just a pitch for a piece of hardware or a clever app. They are proposing the creation of a decentralized early warning network and a community-owned public health economy.
A complete system overhaul.
Yes, it is a plug-and-play model designed to be adopted and replicated by nations worldwide.
Imagine the profound peace of mind, knowing that your local pharmacy or your community center or your village square has a tool that gives you immediate, accurate, multilingual triage.
It changes everything.
You don't have to guess if your child's fever is dangerous. You don't have to drag them onto a crowded public bus, travel for hours to a clinic, and expose them to an untreatable superbug just to get a doctor to tell you to go home and rest. You have a beacon of insight right in your neighborhood.
It effectively lays down the essential infrastructure required to protect our children and grandchildren from the very real threat of untreatable post-antibiotic infections.
So what does this all mean? We've covered a massive amount of ground today. We started by looking at the crumbling, fragmented, and financially extractive traditional healthcare models, using India's pinball machine system of public and private care as our primary stress test.
We then uncovered the terrifying biological reality of AMR colonization, the inescapable fact that the white coats, the stethoscopes, and the physical spaces of our hospitals are highly efficient vectors for superbugs.
We deconstructed why current diagnostic tech and rigid algorithm-based AI fail to spot the subtle, non-binary signs of emerging infections, leading to the catastrophic trap of centralized testing and economy-crushing lockdowns.
And finally, we explored the solution. Dr. Maya's intuitive, context-aware AI combined with the touchlight, decentralized network of Prima kiosks, a system that intercepts the disease in the community, empowers local operators, saves billions in systemic healthcare costs, and eliminates dangerous physical contact.
Which leaves us with a final, provocative thought to mull over. For over a century, our society has universally believed that the ultimate pinnacle of medicine is a massive, shining hospital filled with incredibly complex machines, specialized doctors, and endless beds.
But what if that vision is entirely backward? What if the true pinnacle of future medicine is actually a society so seamlessly connected by intelligent, decentralized information that the hospital becomes a place of absolute last resort?
Exactly. What if the ultimate cure we've been searching for isn't a new billion-dollar antibiotic compound discovered in a lab, but the complete re-engineering of human health behavior?
It's a powerful shift in perspective.
When you look out across that murky diagnostic landscape we started with, the path forward isn't about building a better X-ray machine. It's about building a system so smart that you never need the X-ray in the first place. Thank you for joining us on this deep dive. We hope it changed the way you look at the future of your health. Stay curious, and we'll see you next time.